to be here in person with you all. And it's exciting to discover the topic that we're going to be talking about today, navigating beyond the pandemic, hope for rural housing. We have an amazing array of speakers today. We're going to be sharing with you some updates, some innovations, and some accomplishments. At lunchtime, we're going to be celebrating some of those who have made some amazing accomplishments in the area of rural health for Utah. I want to quote from Phil Pollack from the Center for a Healthier Rural West, who says progress is possible when rural communities come together and rewrite the narrative from unchangeable undersurface to resilience and renewal. That's the message today. Are coming back and coming out of this pandemic stronger than ever. Today, you're going to hear about some of those accomplishments and innovations and future resources. We have an amazing number of educational tables around here today. Please take a moment and visit those tables and find out about the resources. Take their information, share it with your colleagues, share it with your communities. We'd love to get these resources out and about more. We want to thank our sponsors for the conference, and they are found in the back inside cover of your program. And then a special thanks to our co-sponsor for this conference, the Utah Department of Health's Office of Primary Care and Rural Health, who has a table in the back, and you'll be hearing from Ashley, Moritz, and Holly Mills today. I also want to thank our amazing board members and staff for all the detail work that goes into an event like this. Would you help me thank them, and would they all please stand if you're on our board of directors or you help with preparing for the conference? Please stand so we can give you a round of applause. One of the exciting new opportunities we're going to share is going to be shared by my colleague, Casey Shakespeare, who's going to share with us about our new rural project. Casey.
We are very pleased to announce that Utah Center for Rural Health is now a formally recognized project ECHO hub in the state of Utah. We've received funding from the Utah Office of Primary Care and Rural Health to develop our first ECHO series, which will be an ECHO series regarding health equity in response to some of the significant issues that we witnessed through the COVID pandemic. And we're excited to be able to use that project as a springboard to create this ECHO hub that will serve rural Utah as a series a tool that will coordinate with other ECHO hubs in the state, but provide content for rural Utah, from rural Utah, specific to what it's like to be a practicing professional in our rural frontier communities. We'd like to thank the Utah Office of Primary Care and Rural Health for this opportunity and for the collaboration on this project. And I'm actually going to turn the time over now to Ashley Moritz and Holly Mills. I knew that. I just know Holly and I are on first name basis. So you guys can come on up.
Hey, thanks so much, Casey. Good morning, everybody. We're really excited to be here, and that you are as well. Really excited to see a lot of familiar faces and also some new ones, and look forward to having a chance to talk with you. For those of you that are familiar with our work, we're the Utah Department of Health's Office of Primary Care and Rural Health. We coordinate federal, state, and local programs that are aimed at improving the health of Utah's rural and medically underserved residents. So we collaborate statewide with partners across the state to improve access to quality health care in rural and underserved communities. And we're really proud to partner and support the Rural Health Association of Utah for this event, and appreciate everyone being here today. Part of the timing of the conference, you might be aware of, is linked to National Rural Health Day, and the national organization of the state offices of rural health. NOSOR, sets aside the third Thursday of every November to celebrate National Rural Health Day. So that's next week. National Rural Health Day really is an opportunity to celebrate the power of the rural. It honors the community-minded spirit that prevails in rural America. National Rural Health Day showcases the efforts of rural providers and other rural stakeholders to address the healthcare challenges that rural citizens face. Also, like his predecessors, Governor Cox has designated the entire next week as Utah Rural Health Week. So we hope you'll take the opportunity to reflect on the work that you're doing, the impact that you're having on your partners, and show appreciation for that work. Yeah. This year, our team developed a video that we think captures the power of rural. So I'd like to introduce Holly Mills, our team's health system support coordinator, who's going to tell you more about the video and get it rolling.
Thank you, Ashley. Thank you so much for being here. We're excited to be here today as well. So this video has kind of been a long time making. We've really tried to, over the last few years, we've really tried to focus on like understanding and identifying success stories of our work. We've got a lot of day-to-day grant working, government bureaucracy, and sometimes it gets a little hard to manage, but the success stories we hear from you all are what keeps us going, what gives us motivation to plug through all of that on the day-to-day. And so this video, I'd like to thank our team. We have compiled and edited the video, Kelsey too. She did a phenomenal job with the video, and the individuals who will appear in this video, I'd like to thank them as well, and our team member, this creator, is going to get the material. So let's give it a roll.
ideas. How world empowers smaller communities to do things. For example, I remember achieved 90% of their goals with control ownership. That's outstanding. They accomplished this with really staff and it has a relationship with the small community. These are the kinds of results that carry through workplace communities and accomplish. That all of these are much better, the health is not a business to have this, or it should be a business success.
One of the comments I like to make about is the power of small communities to do big things. I think that's what all of you are doing. The big things that you're doing in your communities to help improve their access to healthcare and their quality of life. So I want to thank all of you for doing that. I also want to thank Kelsey and Liz for their work in putting the video together. This has been a fun project for us to here. I'm really excited now to introduce our next speaker. Benjamin Anderson, who's Vice President of Rural Health and Hospitals, Colorado Hospital Association. In this role, he provides leadership and direction, development and execution of the Association's rural strategies, advocates on behalf of rural hospitals and health systems, and works to develop strategic partnerships with organizations that affect the health of rural communities and Americans. Benjamin has 20 years of experience in healthcare and outcomes administration. Prior to joining the Colorado Hospital Association, he served as the CEO of Kearney County Hospital in Lakeland, Kansas, served patients of 30 nationalities within a 180-mile radius. Benjamin is a national leader in health equity and transforming rural healthcare. Since I first met Benjamin in 2019, I really had a chance to get to know him better and learned a lot from him. Process. One of his projects over the past year was the production of a toolkit and playbook, reimagining leadership, a pathway for rural to thrive in the COVID-19 world. Our office partnered with Benjamin and our counterparts in North Dakota's Center for Rural Health to deliver a three-part webinar series on things like physician burnout, board governance, and value-based care. All of these are very timely issues and very relevant to the work that you're doing. As I look around the room, I think some of you might have had a chance to participate in some of those and work with them through that and learn from the process. And I know that we're in today for another entertaining informative session. So with that, I hope that you share my enthusiasm for convention for our next session coming out of the pandemic.
How are you? I'm going to try to do my best and mitigate the echo. I can always use my outside, inside, get out of the house. For your kids, thank you for having me. Thank you for having me, and thank you for letting me bring on this for. Is this side better? I could just use my outside voice. Can y'all hear me okay? Okay, so I may even just stick that up. It won't ring as much. How about that? Can y'all hear me okay? If I use this voice, what does that do for the folks online?
Hopefully they'll still hear you.
You're okay? All right. And if that changes, you'll let me know. It's temperamental. Y'all can hear me? Okay. Thank you for allowing me to bring one of my 4 kids, Maria, here with me. It's super fun to be able to travel with them and to spend some time with you. And I always find when I'm doing these talks around the country, it's the rural audiences that are the most understanding about family. If I want to travel with a kid or spend time with them, it sure helps my wife at the house to have one with me, but also these are times that I think we'll never forget. So thank you for being family friendly. Appreciate it. I'm going to start with a story. 2 days ago. Okay. You want to try this mic? Can y'all hear me now? Is that better? Looks like we did something to address the sound. Okay. Sounds like we're better. All right. 2 days ago, I got a call from the high school CEO. Not different from many of you. Small town in Colorado. So my job is to be the hospital association to 43 tuckered out, scrappy rural hospital CEOs who've been through 18, 20 months of a pandemic. And if N95 say I love you, we find those. And if it's regulatory relief, we call out the surveyors. If it's whatever the thing is they need, we help them out. This guy, I don't hear from him a lot often, not because he's not interested, because he's pretty proficient. He's self-sufficient. He's out there doing his own thing. When he called, saying, "Hey man, I know we haven't talked in a while, but you said to call you wherever the end of the road. We're out of space. We're out of staff. We're out of time. We've got 26 patients in a 25-bed hospital. We can't transfer 2 critical ones out to anywhere in our state. 4 major hospitals in Denver, Colorado, right now. They're not taking it. This is the worst we've ever seen in Colorado right now. And I know, looking at Utah's numbers, which y'all can it's gnarly here too, right? This guy was just calling essentially, saying, can you call somebody, go for prayer or something? Because we got nowhere to go. If we're going to die in our emergency department in our hospital. So, who would ever thought that? And I was with you all several months ago. We thought, gosh, vaccines on its way. We're heading out of this thing. And 18, 20 months in, we're still wearing masks, we're still distancing, we're still washing our hands. And now we've got staff that are in advanced stages of normal burnout. I am curious, we've got a mic that can float around. I'd like to hear from you as we get into this. What are some of the challenges you're facing right now? What are some of the things that you are seeing in Utah and in this industry that are defining after 20 years of COVID-19? And he's got much for it. And state your name, meeting some of you for the first time.
My name is Katie Bryant, I work with UNIS, and I would say that the biggest challenge that we're seeing that folks face in the nonprofit community especially is staffing capacity. I'm working with the hospice organization right now, me, and they can't keep they're doing nonprofit work, free work for folks who are homeless and would die on the street, and have facility for that, and they can't keep enough CABs, nurses, anything staffed to be able to take care of these folks because of the high burnout. They also told me that they increased their rate of pay from $14 before the pandemic. They're now paying over $20 an hour for a CNA, and still can't keep their facility staffed.
Katie, thank you for giving everyone else in this room the privilege of going second. First one to artists, you just took care of it. Like, that's wonderful. What a gift. So thank you. So the great resignation. Anybody get out interestingly. This CEO that I'm telling you about called and said, or he told me just before that, I'm thinking about quitting my job. 2 years old, about an hour a day from here. He wasn't joking. He's at the peak of his earning potential. He's saying, how much of this guy wants to myself, subject myself to? Isn't working. So I think certainly we're seeing among CNAs, medical assistants, dietary workers, housekeepers, frontline folks. I've seen that across the board. Because this has been heavy lift. So that the staffing is one piece. Any others? What are we seeing is challenging now? Yeah. Your name.
So I'm very close to all with the Utah Hospital Association, and I also serve on the Medical Command Response Team in the state of Utah. And the response team is trying to help the rural hospitals with transfer, so they can transfer to a normal facility, call the CRT. We try to help find them. We've done very, very well the last couple of months. Now we can't find beds. It's taking sometimes up to 48 hours. So it's put a tremendous strain on the rural hospitals to have very acute patients in their facilities and nowhere to transfer. We're starting to see some relief. We're slowing down a little bit, but it's very challenging.
Great, thanks for that comment. We head into the winter season where we're bracing ourselves for a head crack. We designed in Colorado, the last time we were together, we designed the combined hospital transfer center where all 103 hospitals in Colorado agreed to guarantee the transfer of Colorado's to somewhere in the state. Everybody got a buddy, and the deal was the urban hospital had to guarantee the transfer, but the rural hospital had to be willing to take an exchange, take an urban patient back out to a rural hospital to take care of them at a lower acuity or more appropriate level of care, so really could actually switch out beds, right? And then there were accommodations we did under the crisis standards of care, and just generally to have urban hospitals actively assist rural hospitals in sustaining a patient through telehealth or home consult until that person gets transferred. And that has worked until about 3 weeks ago. So that's even starting to break down. They're just saying, look, it's 13 hours, 13 hours, it's 13 hours, that's what we've got right now. Where before it was within 2-3 hours, I think it's going to be out. We're seeing the same thing you are in Utah. We're pretty stupid. So the Office of the Inspector General, the OIG, produced a report several months ago that really summarized what's going on in the United States pretty well. I'm referencing this, there are my slides. Read the report, it's pretty well written. But here's some summaries, just around general delivery challenges. And meeting healthcare needs is exactly what you all said. Delays resulting in patients, delays in care that should have happened a year ago or longer that resulted in even a heavier lift. Now, sicker folks that could have been avoided. There's increased needs for mental health and behavioral health, which I'm sure you all are experiencing that. Colorado may be the only one experiencing behavioral health problems. The United States is not really not, but serious, it's like a tsunami that's coming our way right now. There's worsening of longstanding, there's a worsening of longstanding challenges in rural hospitals. We already went into these, in the pandemic, facing many challenges, facing cash shortages, facing staffing issues, facing access problems, and we're seeing COVID essentially put a strain on sometimes the analogy is like when a woman is pregnant, that pregnancy, you can sort of see into the future, it highlights some of the vulnerabilities in that physiology. So if they're prone to type 2 diabetes, we can see it during pregnancy. Prone to heart problems, we can see it during pregnancy. I think the same thing is happening here, where you pile COVID-19 on top of that, you're going to see that. We have concerns about exacerbation of health disparities. We're already seeing disparities between rural and urban. We're seeing exit of public health, medical staff, and other clinical workforce from rural that are exacerbating these access issues. And then there are, we're also seeing, of course, the benefits and the challenge of telehealth. Telehealth seems to be what most politicians in Washington point to is the cure-all for rural health. Like, don't broadband. It's not that broadband is not important, it's extremely important, but it's not good. We've seen some of the benefits of having access to that, and frankly, we won't go back from that, but we've also seen some of the challenges with implementing it as well. So, there are significant challenges in meeting the needs of patients. We've seen we've seen the pandemic with delayed care, and that erosion of trust in hospital safety, like we're seeing some of that happen when patients are dying in emergency departments in Denver of a heart attack. They can't get into a bed. That's happening now. That's happening this week in Denver, Colorado. Maybe Salt Lake is a similar recipe where we're seeing some of the same stuff here. We've seen a concern about the increased need for behavioral health, as I mentioned. Telehealth is a factor. Long-standing operational changes have worsened the problem. And COVID-19 has worsened existing disparities. So, related to staff, so to your point with staff earlier, increased workloads and stress of treating seriously ill and dying patients have led to what Dr. Wendy Dean in Pennsylvania, she's a psychiatrist focused on burnout from physicians, mainly from staff, calls moral injury. It's beyond burnout. Don't think around if we need less than optimal emotion. I'm a work to burnout, Saturday burnout. But really, we really see something beyond that around moral injury, just compassion fatigue from being in a system that is exceeding its capacity for an extended period of time. Hospitals reporting that high turnover and competition for clinical staff created shortages that's basic patient care. It's $220 an hour for a nurse. $60 an hour for a nurse. Which you'll see here. It's over $200 an hour. We're retraining physicians in some hospitals to do nursing care because it's cheaper to pay a physician to do the nursing care than it is to pay the agency to find a $250 an hour nurse. So we're right next to it. I can't imagine it's all that different. With regard to vaccinations, there are positive steps toward pandemic recovery, but it's exacerbated challenge for clinical staff versus hospital finances. Any resistance to vaccinations? Not right. So it has been a really thorny issue in our state, and it is across the country. There's differences in government guidelines regarding vaccine eligibility and prioritization that's created challenges for hospitals. How do we read these mandates? What is this going to mean for us? What's a religious exemption? What's not? What's a medical exemption? What's not? There are philosophical differences between some of the hospitals in our state. When one says, no, we're lenient, go on over, we're the catchers. One CEO said that to the CEO. Yeah, you can go that. I'm just going to sit here in my catchers, but I'll take your staff, right? So that's going on as well when we're not really aligned in that, despite some attempts to standardize that federally. So hospital staff and members of the community are resistant to getting vaccinated. You know, I've seen varying numbers, 1,000 staff nationally, just different numbers around how many are walking off the job if they have to get vaccinated. They're skeptical, they're tired of it. There are challenges ensuring access to vaccinations for rural, senior, low-income populations, even more vulnerable in those situations, and we're seeing worse death rates and hospitalization rates much higher in these populations. Unpredictable and insufficient supply of vaccines in certain cases. And then others, we're sitting on vaccines, right? We're trying to get rid of it, we're trying to use it. With regard to supplies, we've had difficulty maintaining a steady supply of affordable, high quality personal protective equipment, not just equipment. 2 days ago, another hospital CEO called desperately looking for lab test kits, but she just couldn't find some basic. We're still looking for test kits. We're still looking for, I mean, stuff that we shouldn't be dealing with, 18, 20 months into a pandemic. We're seeing that happen as well. And with regard to finances, operational costs have gone up, specifically related to staffing, but also some supplies. Revenues have declined in certain cases that threatens financial stability. Certainly, we're worried about the uncertainty of payment and where's that going federally. So here's some strategies that are being done nationally, but also this is going to be more of an interactive session. We're going to talk about some lessons that we've learned corporately in Colorado and around the country, and engage well in some solutions basically to the rest of this conversation. So here's some things that we're seeing as best practices. One, enhance knowledge and guidance on prevention and treatment of COVID-19. Provide strategic support and increased care to underserved communities. Address hospital staffing needs to help support current staff that are already there. Address some of the structural issues that are driving the burnout. Develop education campaigns for vaccines and the public health issues, public relationships. We've done that to now, but the work continues on. Provide ongoing support on financial issues, coordinated emergency response effort. These are all things that are being done. We're going to talk more specifically, storytelling about how it's playing out. COVID-19, and this is, I think, a brilliant biography of RHAU, UCL San Antonio. I'd like to illustrate something. She drew this up. It has illustrated the fault lines that are already there in our healthcare system. This stuff is already there. It's impossible to ignore, impossible to look away from. And so that is the scenario. So, switch gears a little bit. 11 years ago, I attended a conference in Bristol, Tennessee. It was all the doctors of the administrator of the uniform. Somebody invited me, a friend of mine invited me. This guy named Ross Gibbs that was teaching there. And he's a British philosopher. I'm super great. I'm fancy titles, whatever. Really engaging message. The title of this talk was "Can Freedom Last Forever?" And I vividly remember the contents of this talk, because essentially Guinness said, he said, freedom is inextricably bound to self-restraint. The United States has the best constitution in the world. Everyone else points at us, as speaking loud and look around our constitution, but for our democracy to work, it requires more. It requires people voluntarily to do the right thing. If they're willing to do the right thing, it works. If not, then laws are put into place to protect one person or group from harming another person. The laws in their very nature are the antithesis of freedom, the restriction. So what's that got to do with COVID-19? This week, and I'm sharing a little bit of our dirty laundry. We have hospitals in Denver, 3 or 4 that are on divert, overwhelmed. We have other ones that have not turned off their elective procedures, not even like voluntary or breast augmentations. In fact, they're actively recruiting surgeons who aren't able to do surgery in a typical hospital, but who also have privilege to their hospital. Come on over, bring your breast augmentation surgeries here, while other hospitals are on divert because they're overwhelmed. Freedom requires self-restraint. So what that does when hospitals are harmed is it puts the governor in a situation where the governor can say, I'll start pulling levers to my instruments want. I'll share it all. If freedom requires self-restraint, we have to do it right, even though the laws require it. This work takes everybody, and we have to be on the same page and run in the same direction. And we have a lot with 30 independent rural hospitals with like flex your muscles, independent mindsets. We can do this, we can make it, we're scrappy. And we're recognizing in Colorado that we have to be going in the same direction, even if the law doesn't require it. We're still. We gotta be doing this stuff together. It's collaboration and best practice. We do it as best practice prior to COVID. Now, we gotta work together. We gotta be running in that same direction. But as we engage people, and as we're so tired, we're more prone to start feeling guilt at people, and shame at people, and judgment at folks. Are you kidding me? You're doing that? You're on that train now? Or you abandon common logic, what's your problem? The guilt, shame, judgment, and blame, I would compare to dirty fool. They can motivate and change or even behaviors for a period of time, but it's not the same as a heart change. And that clogs the engine, ends up causing damage in the long run. So there's this concept I can talk about, calling folks out versus calling them in. So I can call my friend, call Mark and say, Dadgummit, get your act together over there. Or I can say, Mark, we've got an issue, we can solve it together. What can we do to solve this together? And I think the latter takes us to be, and we're low on our things, right? But it's really important that we set boundaries enough, maintain enough norms for the real function that way. And function, calling people into this, but still, even as hard as it is, as opposed to calling them out. And it's so frustrating, especially with public health act. Somebody with a rural hospital administration background, to see behaviors in the community, see behaviors among the patients, to see behaviors among the staff. I feel are exacerbating the problem, not exasperating. It's really important that we stop, see the person in front of us, and say, help me understand your perspective. Help me understand what's motivating this. Help me understand what we could do to work together through this process. How do we align priorities as leaders? We have to be a steady guide and North Star for others to come. Even in the most challenging of situations, we have the moral that no one else does, but relying on us, position of influence, in a formal position of authority, to say, we see the right way. Let's get there together. And it involves other folks on the team, leading even when they're not in charge. But there's got to be a leader that sees out ahead and says, no, we can get there, we can do it. Where are the solutions? Where are the solutions? Well, as leaders, we got to begin by listening to the people on the front lines because they know these solutions, and I'm going to give you a few examples of that. Tackling a high employee turnover, bullying, lack of emotional safety in the workplace, and its accusations of racist discrimination. That sounds like all the rest is problems. Just put together. What's up? I was a hospital CEO, and can you all see me here? Okay. I was a hospital CEO, and we had a chronic issue in dietary. Anybody ever had an issue in dietary? Here, staffing problems. Or we had the highest turnover in our organizations in the dietary department. There were accusations of racism. You're racist toward me, you're racist toward me. There were the blame happening, blame shifting happening. There was sabotaging happening. Coworkers, setting one other person up to look as though they made a mistake because they didn't want to work with it anymore. There was just these chronic problems. And anytime a position would open inside the hospital, we had 350 employees or something, so it was not a huge organization. But of these places, they were applying for back, they just went out of the department, so the chief operating officer was exasperated, she didn't know what to do, she oversaw dietary, so the dietary manager, the chief operating officer, and I sat down to try to figure out what's going on, because it's really really expensive and quality is all. So I agreed to meet with all 35 of us, sit down, one by one, 30 minutes at a time. Very time-consuming process, right? We tried everything else we did. So one-on-one, we didn't want anybody else influencing what the one person was saying. So they came in one by one, there was a lot of inflation, other things, other problems that happened. But then we're driving, burnout, we were talking about. Katie, right? So, right? Like Katie was mentioning earlier, burnout, fatigue, we were driving all that stuff. And I wasn't really getting really the root issue. And then the second or third to last interview, a woman walked in who doesn't want recognition for this, so I'll name her. She's Latina American, first generation immigrant, who spoke no English. Walked into my office. I hope it's not scary. I think it's because she's been in the CEO's office before, and it feels like the principal's office. I don't know. So she comes in with a translator that she didn't end up needing. She sat down at the table in my office and handed me 6 pieces of paper. On those pieces of paper, there were 3 pairs that were paper put together. And they were like a grocery list, all skinny pieces of paper, right? She had typed into Google Translate a very clearly defined problem in Spanish, had translated to English, hand copied that clearly defined problem in English for me to see and understand. Even though she couldn't speak or even read the words properly to explain it to me, she handed that to me on the backside of the clearly defined solution to that problem 3 times. You could better believe she had the CEO's undivided attention when she did that. As it turned out, with those 3 ideas, turnover went down, police satisfaction went up, and the drops said, as it turned out, chief operating officer had a sister who was struggling with some acute mental illness, who was working in there, and there wasn't a sense that that person could be overcome. And that was creating all kinds of punish, right? That she had the courage to say to me, right? So if there was ever a person who would be unlikely for that to come from, her dishwasher in the kitchen. We engaged her mind to solve problems beyond using your hands to wash dishes. I think that's better at it. Never seen that the way that she saw it, but she did it. Here's another example. We had an M&A problem, M&A turnover issue. You mentioned the entry level or lower wage workers, right? Hard to maintain. So it's constant churning and turnover. This new graduate position just got there. We had 3 MAs in his first year. He's super frustrated. He highly values efficiency and respecting people's time. He likes his time to be respected. Couldn't get his footing in the clinic. Just couldn't get organized enough to be efficient. So, waiting, or patients are waiting, or things were scattered. And MA is so important. Well, and so he's put something on my schedule and thinking about MA turnover in our session where I get to hear about how I haven't fixed the MA turnover problem, right? That's not what happened. It's not what happened. He came in and sat down with me and said, I think I have a solution to the MA turnover problem. And I'm thinking, okay, where would your mind go? What's it gonna cost? Okay. What's it gonna cost to solve it the way you would like to solve it? I'm all ears. Talk about it. He said, well, we have 13 MAs, and I think they're underpaid by about $3 an hour. So I keep hearing the MAs that are leaving, they get jobs for $3 or $4 an hour, so about $3 an hour. They're underpaid. So I got with the CFO, and I figured out if I gave them all $3 an hour pays, that would be one stabilizing factor for the MAs. So we wouldn't lose them because of their jobs, and get them also to a living wage where they'd be able to make it in our community, this kind of money. And he said, so that's not free. So the CFO told me how much that is. It's about this much money. So we get paid this much for ER call. It's kind of like a bonus for us, I mean, it's an add-on to our contract, keeps us around, stuff like that. But a stable MA means a lot more than being paid for ER. So if we adjust our ER call, position about $3 an hour, it'll pay for all those increases for the MAs. And I got all my physician partners to agree to that. So all you can do is just do an attendant of all our contracts and take that money and give it to the MAs. And then also, we're going to require them to be for them to complete an online course, a certification-based course, so we can improve the quality of the MAs by investing in the kid that they'll feel invested in, they'll feel better about their work. They'll get paid a little more and we'll learn some loyalty that way. You think we can do that? Yeah, I think we can, and within 6 months, and turnover can stabilize. In either case, I have an answer. These are addressing some of the most thorny issues that we're dealing with right now. But they're structural problems. No breathing exercise is going to fix that. No mindfulness course can solve that. No matter how mindful you are, it's still dysfunctional work. No matter how much you breathe, how deep you breathe, how frequently you breathe, still underpaid. And both of those solutions were cost neutral. And they came out of people that were staring the problem in the face and not me, not the CEO. And we're easy to CEO is the blame. I mean, talk about people blaming me and you're the easiest ones to blame. They pay you the big bucks, don't they? Why don't you solve the problem? Right? But if we can engage people on the front lines to solve those issues, we can really get somewhere, even in the situation you described right now, even with those thorny challenges that are happening, even then. We're doing this in a more intentional way, so Ashley wants. All right. Somewhere. Ashley's one. Thank you, Ashley. Ashley is a visionary. He and another leader in North Dakota piloted some case-based learning is online. Really never been done in charter business school style learning, especially in a rural context before. They pilots like that to encourage solutions-based thinking for you to work problems. But the key with that case-based learning was to focus on solutions-based thinking and equip people with tools to solve their problems. So we actually built on the vision around what was happening in Utah and North Dakota. Took that person to Colorado, took one of those cases that we worked on. It was called the burnout that they talked. Took that into a behavioral health system on the western slope of North Dakota. And got 50 very tired behavioral health workers, all levels of the healthcare delivery system together to look at a burnout issue. Some of you remember this case? So what we did was we took a 6-question tool at the end. I'm going to mention this in this conversation. And the 6 questions are: what outcome needs to be driven? Who are the stakeholders? Where are there opportunities to share? Why isn't it already happening? How do we measure success, and when do we expect to see progress? We took those 6 questions. Everyone in the audience, the last 20 or 30 minutes of this session, filled that out, literally like a worksheet. And take things, what outcome, what one thing would I want to do? Who would I need to call into this one that's calling out? And then what can they contribute on? We harvested those ideas. Collectively collected, that's the goal. That's like employee satisfaction survey with steroids. We were calling the sessions and frontline workers, other people in solving these thorny problems. They sometimes can see simple things. Sometimes they don't even know how amazing that idea is. This is what I would do. And one receptionist came up with a staffing change in HR. And the executive team at MindSprings Health, as Dr. Amy Gallagher and I were teaching this, they took that, they implemented it, and it was effective. First of all, it helps the whole organization. What it did for that one receptionist that had that idea was solidify her tenure in that place, and she would probably otherwise left. Even though she'd get a pay raise, she was thanked by the executive team for that idea, she'd get a pay raise, she was so grateful, that they heard her, that they were able to to make a systemic change in HR process that would improve their ability to recruit their staff. So it's really important that we're harvesting, intentionally harvesting these ideas from team members as we need to solve them. So this is an outcomes framework that I based about the career at the top of this, is health outcomes, in the middle of decisions that lead to health outcomes, the individual responsibility, the things we do to health outcomes as individuals. The bottom is the factors that lead to decisions that lead to health outcomes, the human condition. The core issue which determines health are the systemic things that lead to outcomes. So as we think about the outcomes within our organizations, there are individual behaviors among our team members, including us as leaders, that determine those outcomes within the underlying factors. And addressing those systemic issues does in fact require all of us, but you can't solve structural problems with individual solutions. Breathing exercises will never fix cost schedules. They just don't. They never have. Mindfulness courses don't fix a funky culture or a broken EMR that keeps us trying until midnight. It just doesn't work that way. We have to know which are which individual problems can we solve with individual boundaries and individual solutions, and which ones are systemic and structural. And the structural stuff is hard. So here's the hard part. There's no way of avoiding this stuff. Another mindfulness course doesn't get us any closer. We have to roll up our sleeves and do the gritty, hard work. The good news is, CEOs, as roll up leaders, we don't have to find all the solutions. They have. The people on the front lines have them, starting to offer. And if they're sitting in meetings, just to sit in meetings, that's one thing. Right? That might handle the boss. But an intentional strategy around harvesting ideas and solutions based and implementing even one of those solutions and waving the flag out and encourages others to go, gosh, we listened to her. We didn't listen to me. We get to the next one, we get to the next one, we get to the next one. Actually mentioned this playbook we published a year ago next month. We published a playbook around growth and we're bringing the COVID-19 world. And this is 134 pages, in my opinion, very helpful information. There are 9 authors, mainly Dr. Warren Hughes and I, Dr. Hughes, founded in Pennsylvania, we're all models. She's an academician, she's an MD, MPH. She's the fancy academician, I'm the scrappy little guy. You guys gotta do this. It really is meant to be topical, and so if you're looking for a tool that can help you get down this path with staff to solving these problems, rural code with Paul Rath, that you Google for something that comes up, it's free, you can have it, and then particularly it's case-based learning, so your teams can read the cases and see yourself and these people, because they're fictional stories, poetry stories. The text that shows up, the fish tank and goes over his head, his dad yells, "You're not going to make me wear a mask, this is my mask." The trash bags, so you can't find PPE, and people calling off work because they're burnt out, tired, surgeons jumping because surgeries are canceled, all that stuff. The staff really goes rogue, goes to the media and says that, her employer is misrepresenting COVID data, and NPR gets involved and whatever. All of that stuff is in there. But the strategic prompts in that playbook are very helpful. They're simply framed as, have you thought about this? Try that. You thought about this in your own context. It's akin to Patrick Lencioni's 5 dysfunctions. Like, what? I see myself in that. Maybe that's what's going on here. Maybe this is how we can solve it. We can't wait on the federal government to fix our problems. That's on us. We fix it. If we really are our city, our strategy, and capable, we'll fix it. Now, we appreciate some regulatory relief from Salt Lake or DC, absolutely, right? And there's a place for that. I mean, a lot of that we're doing. Colorado is focused on regulatory relief, but we can solve a lot of these issues without waiting for them to write those states. We're capable. We're smart, we're scrappy, we're hardworking, we solve problems all And we can solve these ones too if we do it together. So I want to spend these last 10 minutes or so mining stories and ideas from you. When you look at this image, what story in your world comes to mind? When you see this one. So for me, I'll give everyone else that. Right? Thank you last time. There was a woman who died in a car accident that was working on our hospital staff. She was in She was texting and driving down a 2-lane highway, and a semi stopped to turn right. Standing still, she didn't see it, 65 miles an hour. Right, she's a huge mess. Devastated to our staff. Mom worked as a nursing home, was attached to the hospital, everybody in town. They were a lucky gal. She was 21, with a wife in front of her, newly married. I remember thinking when that happened, I should feel awful about this. That's terrible. I do all the right things to say, so sorry, condolences, these flowers, I help, let's take time off, for the mom, things like that. But I felt nothing. When that happened, I realized there was something broken in me. And I desperately wished to be seen at home. To be seen by a board who was supervising me. To be seen by colleagues and coworkers, or others like, hey man, are you struggling? Are you okay? It's super critical to be quiet struggles of others, and that journey took years. Took years to do some really intentional counseling, therapy, and behavior changes, and environmental changes, things like that. So that's the story that comes to mind when I see this. I don't need to tell a story about you, but I'm curious what story comes to your mind when you see an image like this. Yeah, Mark.
I'm sure I have a bigger story, but I guess kind of reminds me of a lot of our staff in hospitals put on a great face and act as though nothing wrong was going on. Wasn't amazing. Not much television, which is last days. But somebody just lost their husband or wife, and somebody would say, "Are you okay?" I always think that's a stupid question. Ask that question. And yet our staff put on a very great face, and they tell patients they're fine and they're okay. And then sometimes dark shadow sort of by themselves, they're holding themselves in this tremendous stress and depression, and they need someone to feel it.
That was a really insightful, thoughtful reflection. It's this concept, Mark, I think I'd call it white knuckling. In rural white, I mean, those who are used to wear white or like sometimes it's hard, it's great, it's, we'll make it. There's a book called Try Softer by Arnie Colbert. He's a licensed professional counselor, Colorado. And really, I read it today. It's a weekend reading, but it really is this concept around addressing this tendency to white knuckle our way through situations. And yet sometimes that's all we know, like that's all we can do. And yet, like there's some people, yes, there's violence. Who's going to die today if I don't show up? And who am I going to dump on today if I'm not there? They're going to have to carry everything that's happened to me. So we're squeezing every bit of everything left in us to do that, but we can't get what we don't have. It's really hard, so thanks for that reflection. Any others? When you think of this image, what story comes to mind? See this. Yeah.
So we do part of our work, which is to say that this to meet with different clinics and different hospitals, to understand what they're doing. And this is kind of already been touched on with we were talking about challenges, but remember going on a site visit, back in July, just as the Delta wave was starting to get big here. And this the staff I was living with, was talking about how they had people in their waiting or in their emergency room that had to convert from beds to, that's because they didn't have any words for their patients. And it just, that really, I mean, I know that's an issue, both urban and rural, but it was extremely, especially pronounced in the rural area.
Thanks for sharing the wizards.
Holly.
Holly. When you think of this, when you see this image, what thought or story comes to mind? You can't solve structural problems with solutions. What's to mind? You see this image, what thought or story comes to mind? Yeah.
Any nurses in the room will know that Florence Nightingale carried the lantern. That is the symbol for all nursing. So, of course, this immediately brings that to my most critical group in our healthcare system. And they will light the path for others, but just leave it for them to.
That's wonderful. Florence Nightingale. This is certainly one I'm taking with me. What a hero. Also, trendsetter, trailblazer. Others comes to mind. Your name.
I'm Liz. I'm with Apple. Finding out in July, through my master's, comfortable, awesome. And it's just a way. And it's thinking about my career, about that as a second career. And I did my patient on reducing mortality specific population. And it was just a real awakening for me to realize that I was able to home. I can't just go into the community and offer patients. I have to find a way and reach out and ask them what the solutions are and help their community. And it was transformational, changing for us.
That is really insightful. So it seems like in hospitals we ask when a patient uses the sheets for soft, that was comfortable. If the nurses from ICU, if they use more, we're asking about mental services, right? Essentially, we're asking, how do you do? What should we be asking the patient when they leave the hospital? How are you? Do I have that to back if I don't? Can we find it together? Because I may not have it. I wouldn't know if I don't ask. That's such an important question. Stop, look back and say, one direction. What's the right direction going? The story that comes to my mind is around that is a patient that had chronic diabetes, diabetic neuropathy, or poison eating, over and over and over again, not compliant. Terrible choices. Wouldn't you just eat right? Why don't you just start exercising this way? And when a clinician or a physician finally sat down and said, what matters most to you? What do you influence? What would bring you joy? He said, well, I want to go fishing with my grandson. That became the North Star. Well, what do we have to ensure you get in that boat again? And go fishing with your grand. The behaviors change, everything else changes. But came down to what really mattered wasn't actually addressing his diabetic issue. The diabetic stuff, that became a pathway. That's what brings me joy. And I think that is so important. Thanks for sharing. Any others on this? Yeah. That's right.
So when I look at this picture, I think about leaders. I think about the book Leaders Last, and I think each of those people symbolizes each department in the healthcare system. And that makes me realize I have a lot of experience in administration. So I feel like administratively, we see each department, and I feel like the department needs a leader to fill those cracks, to be the one to eat last and make sure that the department, we need to be more accountable to look at each employee and ask, how are you doing? What is your goal? Not just professionally, but personally. And shining the light for them, taking that leadership. And I see faces around the room, and essentially we're going to be the leaders taking this information back to our healthcare systems and organizations. And so I feel like even though we do need to fill in those cracks, we still need to ask those smaller questions, being the leader.
Columbia. That was a lot. I'm going to finish with this topic because I think we've got 2 minutes left, right? It reflects on exactly what you're saying. How many of you familiar with the Institute for Health? IHI, so look at, right, they're like the fancy quality improvement folk, right? Well, there's a co-founder of that organization, 2 founders, one's named Don Berwick, folks know Don Berwick, who was at the same as Australia. Another one named Warren was young. Warren and I are very good friends. I was at her house a couple weeks ago because I was doing the main roll call conference. With this group and doing. I stopped by her house. She shared with me some wisdom in preparation for this, and I'm going to leave you with closing today. She said when she was a hospital administrator at the time, it was Massachusetts Rehabilitation Hospital, Mass Rehab. She said 2 questions changed her life and work that I believe exactly what you talk about. One, which she said she started a process by which she was asking patients in their system was asking patients, either documenting or electronic questions. One, what brought you joy? What brought you joy? And the second question is, what matters most to you? That actually went in the electronic as one of the most important pieces of information around building here. She said, we didn't stop there. We didn't stop there. Developed a system whereby staying views around in the hall conversations, I started asking the staff, what brought you joy? When's the last time you felt joy? What brought you that joy? What matters most to you? Even if it has something to do with work. She said, I didn't stop there either, I took it home. I started asking my kids and my husband every night at dinner table. Every night, together. What brought you joy? What matters most? She said, I got to know my kids in ways I never knew. By simply asking these questions and listening to the answers, she said the most important piece was I carved out 15 minutes every single day. And I asked myself, what brings me joy? What matters most? She said, because you can't give what you don't have. You can't pour out. So she said, start with the end and start with the backwards. work backwards, start with you. And when she has challenged me to do that, I'm trying to remove those, and I ask myself, what brought me joy? What matters to me? Because to ask myself those questions, and to act on that, to fill my cup enough that I can pour into someone else, that I can live out my faith, my belief system, my mission. By first ensuring I've got something good. Thank you so much for the opportunity to spend this time again before. Thanks a lot.
I always enjoy listening to that speaker. I'm glad this got recorded because I've had a couple things I'll get to watch it again. But can we get another round of applause on that? We reached the part of our conference where we're going to begin our breakout. So I just want to kind of orient that so that the campus can be slightly confusing. We have 3 different sessions that we'll be running during each breakout time. And you're going to locate those rooms. The breakout B room is actually just directly behind this wall, so you're going to exit here and take a left, and it's going to be right out of these doors with another door into that room. Our conference room D, you're going to exit, go to your right. There's a little cafe right outside, and then just for reference, there's restrooms right next to that cafe and the restrooms. Conference room B is going to be right next door to those restrooms, right down this little hallway. And then if you're going to any of the sessions that are in the hall and building, that is this building, this big, nice 5-story building that's directly this direction from us. So you can exit out these doors straight out and walk down the sidewalk. Or you can go the same direction past conference room B, go through the cafe, and there are some doors that you can go down and right into the hall building. You'll know you're in the right spot for the hall building because you'll see the big bronze buffaloes action between this building and the hall. When you go inside, just go through those front doors. There are elevators just inside to your left. You just take the elevators to the 5th floor, and then the conference room you're looking for is right outside the elevators to the left. So if you get lost, we should have staff scattered throughout the area. But we'll have a breakout session now. We might get there now, and then there'll be a 15-minute break in between. We'll have a second set of breakout sessions, and then we will return here for lunch. So if you guys have questions, just find the staff member, we can help get with the chat.
Yes. Yeah. Oh. Oh.
Okay.
So start right now.
Yes. Okay.
Your back on your, maybe by the chair for now, it's you. Or you need some- Do you want to step closer?
wondering. PowerPoint. And can I just put a lot of stuff in there. Because I don't walk around a lot, but to walk. Oh.
Would that be better to hold it, or you want one of the headset?
I brought my.
Or you brought your headset?
If I can. Someone around.
Let me get some, let me get a tech person.
Whatever works best.
One other thing, we have a video that won't play with the video and the sound. I tried to upload it. So we might need to have you play the sound. Can you play sound separate from me playing video on my computer? So let's just get some sound going and then we'll figure it out.
So.
So exciting. So fun. Thank you for work. Well, kind of. I'm still on the phone and on the email and, you know, a little bit. I'm off. I'm out of the office. But my mom is staying with our children and we learned this morning how, man, it's picture day. And I'm like, oh, I wish I would have been paying attention to the whole world. Yes.
I could do the PowerPoint right here, but then
it'd be easier if I was sitting here in front of the board so that I can run the show for him. He speaks and plays the guitar, he can't be fiddling with.
You should have.
Oh, if I can click it
are
from.
on the other side of Utah now.
We were.
Oh my goodness, here in Capitol Reef this spring is so beautiful. Oh my goodness, so come stay with us. We would love to come back. We had such a blast. My son still, I think, yeah, but we just had so much fun. We would go out to Capitol Reef and Goblin Valley and Canyonlands. I mean, we would, you know, start at Moab, Canyonlands, Goblin Valley, Capitol. We had a great time. So where's your in there? Because we would went to the little pioneer village. We had just such a great time.
he is doing.
Yeah, we've done that one part.
Oh, my goodness. Oh, my goodness.
There's a family.
Oh, we would love to come see it. We'd love to come spend time with you. Just learn more about you.
Oh, that's yours? Okay.
So Chris,
This word, the presentation.
okay. Yeah, let's see if we can grab.
What do you want your PowerPoint?
I-
That's what I'm trying to find right now.
So here is.
Yes.
So this is a PowerPoint clicker.
Oh, yeah, I know how to use those. So will it, from a distance, can I be down here and it'll work?
Yeah.
Okay, that'll be good.
If,
Thing is, like, oh, we'll be able to see what's up and coming, because it looks like it's coming, so we'll figure it
you
out.
have a cord to put on, you might find far.
Amplifier.
An amplifier. That's me.
Here's the I know. I only smashed those. It's so funny. He does a great job. But
Microphone for me, that is,
On this podium.
we have
mine's here, I was just.
I don't think we do. Jacob, the guy that was just here, can you a little bit more back on the stage?
No problem. No problem.
You don't want to.
Okay.
Me too.
So. Really quick.
Get your guitar out. Oh, sorry.
You're just correct. I'm just gonna bring it over here and. This is what we got. So, other great things that you like. Would you mind?
No, I actually love the reception. Yeah, absolutely. I'm so excited.
How many other people are on the team?
There's there's somebody from the state coalition. And there's support.
Yeah, there's just has a few pictures. Normally I have there's a bunch of files, you know, on checklists. Things like that.
And
class? What do you mean, because, yeah, because
Yeah, and then you just say that, say what's gonna be different, or, you know, that might say that you have.
okay.
Yeah, oh, you don't have much to say, that's fine, I got some written down.
I know.
Actually, it's not in there. Can I? You're so wonderful, thank you. And the next one starts at 11? Yeah, that's ours, yeah. Okay, so we'll hurry and get things squared away.
Working on it. Good. One sense, so this one here, that's for.
Okay.
One, so like just in the back here.
Okay.
And then. And. There is, I've got.
Okay, let me get out the computer and just say that.
Where are? Let's try this. Now, I need to, grab some batteries for. Batteries. You guys are so I'm thankful for your help. Then let's see. Oh, and I'll just need the headset from you. And then I should grab where it might. Chris, this tie or the other one? Where is?
We're getting somewhere.
this part to it.
I'm gonna run upstairs and see if we can get to our little control panel in our area there. And I'm gonna test the volume. So once I get up there, you can turn it back on. Okay. Absolutely.
I have some photos.
I'm
Not quite. Battery. My guitar.
You said you put, was it this one that you put on the picture?
What's that?
Was it a different thumb drive that you put on the picture?
That one.
This one?
I put several things on there.
See the one where
Oh, no, it's not, sorry, it's not that, it's not on that one, it's on a different one.
All right, well, we gotta find that other thumb drive.
It was,
I gotta remember where it was, because I remember seeing it.
it was, yeah, I had it in the,
It wasn't in that box.
no, it was like in, right by the computer.
I brought what I thought I saw in by the computer. I brought both thumb drives, I thought. I just have to figure out where I put it. Because I wonder if I have it in your overnight bag. Is it on your website? Do we have that one on your website?
Yeah.
Oh, well, I know.
We both need it. Oh, we like it. You want to set up? Yeah. So anyway, we're good. We're good. I want to look at it. don't, I know a lot of people they are, just understand structure. You know, unfortunately, probably somebody else.
Are you able to see anything? Check the soundboard. Go for it.
Oh, I heard it.
Say that, yes. Test, 1, 2, test. Testing, test, test, test. Testing. 1, 2, 3. Hi. Hello, hello, hello. Hi. Yeah, thank you.
You don't need this. Might have to run back up. I can't find that other. I looked at that one picture, I just got it. So the car's not far, I just need to get it.
So, are you still going to be, I think you said, kind of working remotely?
Yep, I get to work in the university, it's good for me to work in Melbourne. That is amazing. Off the grid, like out in the middle of nowhere. You know?
You say this is a good reason, one picture. But goodness, she doesn't.
What was, Chris? What, the book, what's the?
Shirley Baldwin. And it's a wonderful book. I was like, if you didn't have bought a house with a septic and a well and replaced 5 cars, lots of cars, I'm like, it's ready to go. She had it in 2 years ago. We just can't, right? I'm like, it's somewhere there. Like, you gotta get, you know, we hope our whole community
So that's our.
Chris,
Yes.
my, here's my, I'm trying to find my talk.
Is it written out?
Yeah.
Right here. That is by this one, this one. Yes. Oh, yeah. Then a binder.
Oh, thank you. See that.
Be something else.
I'm going to
Find one more thing.
learn some things. It's just.
Yeah, that's what I'm trying to do. Is something else. Thing behind you, don't step on it. Where'd you put your external? Your external hard drive?
Was even more.
Oh, it's in my, oh, I've got to go out the car for sure. So let me go do that. Right, I really do have to go out to my car. Thank you.